Good afternoon, everyone. Today we are going to have the Organ Donation Committee CME, second CME of the year 2024. Now I call upon Dr. Suguna, one of the members of the Organ Donation Committee, to give the IMA prayer and physician's prayer. Yes, madam.
IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and fear. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I rely on thee. Thank you, sir.
Now I request our President, Dr. Abul Hassan sir, to give the inaugural address and inaugurate the program.
Thank you very much, Rajesh. Respected office bearers, IMA TNSB, Under Secretary Dr. Kasi Prabhu, President-elect Dr. Singhatwan, faculties of the today's meeting, Dr. Raghavendran and Dr. Saravanan, and all my dear IMA colleagues. It gives me much pleasure in continuously bringing this organ donation committee meeting to upper levels, the next levels. I congratulate Dr. Rajesh Babu for taking up this particular cause very seriously to his heart and is working on this dedicatedly. And I think IMA is an important stakeholder in the organ donation activity is concerned, and also the transplantation medicine is concerned. There are so many political issues in this organ transplantation. IMA has been always vocal and vociferous in bringing out changes in the Transplantation Act, and also encourage organ donation from the people. And we have to go a long way in bringing up this organ transplantation medicine, which is a very important milestone development in allopathy. And we will have to work hard and sensitize people to donate organs at the time of brain death. Hence, today we are going to discuss about brain death and other aspects of organ donation and transplantation. I would like to, mention one important thing here. At the end of the year, after doing lots of activities, various activities, month by month in this particular forum, Organ Donation Committee, I wish to see many of our colleagues, our doctors, becoming organ donors by having an organ donation card. I think we will be issuing our people, like other organizations are issuing donor card. We will also give a donor card at the end of the year to those people who are going to pledge their organs in the unfortunate time of brain death situation. That will be the very important perceptible change you would, as an organization, would give to the society, that the doctors are in the front line in the cause of organ donation. Doctors are in the front line in donating organs, and doctors are in the front line in propagating this message of organ donation. So I am very happy we are moving in that direction. And once again, congratulate the entire team for taking up this cause very seriously. And I am very happy to inaugurate today's seminar. Thank you very much. Over to you, Dr. Rajesh.
The organ donation committee, what we have in Tamil Nadu is myself is the organ donation committee chairman, and our team members are Dr. Kalidas from Chennai Perambur, and Dr. K.B. Sivaprakasam from Atur, and Dr. G. Srinivasan from Karur, and Dr. S. Papaya from Madurai, and Dr. T. Kanagachala Kumar from Erode, and Dr. T. Saravanan from Erode, and Dr. G. N. Suguna from Atur. Dr. Kalidas, Dr. Sivaprakasam, the Srinivasan, the Papaya, Kanagachala Kumar, T. Saravanan. The main aim of our organ donation committee is to propagate the message to all the IMA members and the doctors to give the awareness about the organ donation. That is the main aim. And we are going to conduct periodic meetings periodically in common places in the IMA to give more education for our people about the organ donation, because our medical people also are not aware of a lot of queries they arises in their mind. So we like to clarify all the doubts by conducting the periodic meetings in every month. Every month, last Monday of every month, we are going to have the organ donation committee CME. And each month we will be having different topics. For example, next month we will be having regarding the kidney donation, and the subsequent months we will be doing the other donations. So I invite all of you to attend the meetings and get the education about the organ donation and spread the message to all the people. That is the main aim of the thing. And we are going to come out with a new emblem for the organ donation committee. And also we are going to have a small handout which is printed with an IMA banner, and which will be issued to all, so that all the queries will be clarified. The organ donation, the registry created in IMA Tamil Nadu website, as it is given in the next page. For the pledging of our organs, willing can and get the donor card we will be issuing. This is the manner in which we need to register in the Tamil Nadu IMA. This registry is only for the IMA doctors. And the same way, we are going to create one more form for even for the general public also. That also we will be putting it in our website. Here, what we need to do is go to imatn.com website, and in that click the imatn.com or IMA Tamil Nadu State Branch. On the right hand top, there will be one thing called as applications. In that, if you click it, the organ donation volunteers will come. And then in that IMATNSB organ donation volunteers, and a Google form will come. You have to fill up the Google form, fill up and submit, and already you will be registered. So actually we are having a less number of registers already in the thing. Around 57 people only are registered. This is the method of doing it, and this we will be publishing in all the places, and so that the people will be registering, and subsequently we will be issuing a card for that. This is the donor card which is being issued by the Tamil Nadu Transplant or Tamil Nadu Transplant Society. And this is the card which I have downloaded by registering in the Transplant. This is what they are giving. And in that, if you see that about all the organ donations and everything, and then the person who is to be contacted, everything will be given in that. And then actually, today meeting, what we are going to have is we are going to have the talk by Dr. Raghavendra sir, and subsequently, before that, we will have the felicitations by our members, our main office bearers. Now I request Dr. Karthik Prabhu to give his felicitations, our state secretary sir.
Thank you, Rajesh Babu sir. Most respected state president, all leaders, dignitaries, good afternoon everybody. This organ donation awareness committee is a brainchild in this year by our state president. And for its chairman, we all unanimously thought none other than our Dr. Rajesh Babu, who is very actively involved right from his Coimbatore branch to everywhere. Wherever he goes, he carries a lot of cards to make people, motivate them to get into organ donation. So I congratulate him for the nice work done, and all the committee members who've been handpicked to make this awareness go in a big way so that a lot of public gets benefited. And we also have a very important social phase over this committee. So we need to be very careful, and the approach should be very clear and modest so that people and public trust us to take this in a big time forward. And I also request all our members also to be part of this and also to register as Dr. Rajesh Babu requested. And I once again congratulate Rajesh Babu sir and his team. All the very best and best wishes. Thank you, Rajesh Babu sir. Over to you.
Thank you, Karthik sir. Our President-elect, Dr. Sengutuvan sir, to give his felicitations.
Thank you. Thank you, Rajesh Babu. Respected President, Dr. Abdul Hasan, Secretary Karthik Prabhu, and Organ Donation Committee Chairman, Dr. Rajesh Babu, and speakers of the today organ donation program. And Dr. Rajesh Babu is well planning this organ donations meeting, and he is giving much importance to the organ donations. What all to be done, what all to be not to be done. He has given everything has been pointed out, and this organ donation awareness is much more important for this field. So our president has formed many committees that is beneficial to the members and also to the public also. So I wish Dr. Rajesh Babu and his team for doing many things great. Thank you for the opportunity given.
So today we are going to have the program about the first and foremost thing about the organ donation is the brain death certification. That is the main important thing. And so today we will be having the brain death certification talk by our professor and HOD of MMC, Dr. Raghavendra sir. Dr. Raghavendran is the Director and Professor, Institute of Neurosurgery, Madras Medical College, Chennai. He Professor S. Kalyanaraman Gold Medalist for Best Outgoing Student in MCH Neurosurgery, Best Doctor Award from Government of Tamil Nadu, and Medical Excellence Award for Outstanding Contribution in COVID Management, contributor in South Asian edition of the textbooks Dijong Neurological Examination, Paul Brace's Clinical Localization in Neurology, Neurological Examination by the Jos Billiard Operative Neurosurgery Atlas, published by SGP PGMR. The Senate member of the prestigious Tamil Nadu Dr. MGR University, member of the Super Specialty Board of Studies, member of Administrative Board of E-Journal, and editor of Neurosurgery Section, member Brain Death Committee Transplant. That is the main important thing. And Secretary of the Chennai Neuro Association and founder member of the Tamil Nadu Association of the Neurological Surgeons. And so I request our speaker of the day, Dr. Raghavendran sir, to start.
Most respected Rajesh Babu, Chairman of the Organ Donation Committee of IMA, most respected President, State President of IMA, the other senior officials and office bearers of Indian Medical Association, senior doctors, friends and colleagues. I extend warm greetings to each and every one of you. It has been a pleasure to be among all of you here, and brain death certification and transplantation has been one of my passionate subjects and topics. I've traveled all over India, I've spoken in many places on behalf of the National Organ and Tissue Transplantation Organization. And it is an honor to be present here among all of you today. So with the blessings of Almighty, the mythology behind the image of Lord Ganesh with the elephant head and body is relevant to our topic today. See, we all know we have transplanted everything right from head to toe, the hair, cornea, heart, lung, kidney, intestine, skin, everything. But are we capable of doing this head transplant or brain transplant procedure as human beings on another human being successfully? It cannot be done. It's not going to be possible even after 100 years or forever. That is exactly what brainstem death means, and that is what we are going to discuss today. So this is where I studied my UG, my PG. Before we start, we all know life needs light. Without light, there is no life. And the sun is an eternal source of life. But in effect, the human life is like a candle. It burns itself down and gets exhausted at some point of time. The duration may vary depending on the thickness or the height of the candle, but ultimately it gets extinct. That is exactly what we are for. So how to keep this burning, that is what we'll see now. So let me go briefly into the concepts of death. Death has been happening right from the ancient times. When the first animal came into being, it had died. So how was death identified and diagnosed in the ancient times? So anecdotal references in caves tell us that when somebody closed their eyes, not able to open their eyes, they were called dead in the ancient times. And when all body movements stopped except breathing, they were called more dead. And when somebody stopped breathing, they were called completely dead. This was the ancient terminologies. And over a period of time, it has modified. But ultimately, when somebody stopped breathing, they were considered to be dead. But there happened a paradigm shift in the 1800s when Sir William Harvey identified the cardiac circulation, and Lennox invented the stethoscope. We were all told cardiac circulation is the most important aspect for survival, and heart sounds is the indicator that the cardiac circulation is intact, and that could be heard with the stethoscope. And we had a paradigm shift. We were fascinated to hear the heart sounds. That is one thing. The other concept which I want to mention here is death was visible in the before 1940s, because 90% of the death happened at home in front of the relatives. Sometimes the priest, the sick were anointed, and everyone in the locality or neighborhood knew someone is terminally ill and death is imminent. But after the 1940s, medicine as a science advanced at a very rapid pace, and intensive care became a norm, became a possibility. It became advanced so much that death started happening within the ICUs, away from the vision of the relatives and others, and that is when death became invisible. So today we all know most of these, even now, deaths do happen at home, but most of them happen in the ICU. So if we look at the history of brainstem death, it was discovered, it was not actually invented, because in the early 1940s, for the first time, Danish medical students for the polio victims did a small tracheostomy, inserted a tube and was able to maintain respiration with hand ventilation. And in 1950s, Sir Egas Moniz, he invented the cerebral circulatory angiogram in Portugal. Then in the mid-1950s, mouth-to-mouth resuscitation or cardiopulmonary resuscitation became prominent, and mechanical ventilation became a possibility for a patient who is not able to breathe. And in same 1950s, the first successful kidney transplant was done between identical twins. And later in the year 1959, Mollaret and Golan, the French physicians, proposed the neurological criteria of death. So this is in brief the history about the brainstem death discovery. So improved ICU care led to patients who were in irreversible coma could be maintained for a prolonged duration of time. And this is what they described as coma lidipas. These patients were in deep irreversible coma. They could not breathe on their own. Their brainstem reflexes were absent. Most of them had diabetes insipidus, cardiovascular system instability. They were poikilothermic, and all these patients had asystole at some point of time. There was a small differentiation the physicians could make in such patients. Egas Moniz has invented the cerebral circulatory angiogram. So what they found out was all patients who had absent cerebral circulation did not survive. and a few patients who had an intact cerebral circulation, not everyone, a few patients who had an intact cerebral circulation survived, but none with absent cerebral circulation survived. So that is why they proposed absence of cerebral circulation indicates loss of brain function, brainstem function, and brain death is something which is irreversible and can be considered as equivalent to death. So why did this happen is because of the cardiopulmonary resuscitation mismatch. Most of you would have had the pleasure of restarting a stopped heart, which was an asystole. You could have defibrillated and restarted it. Yes, the heart would function on its own. We can pace with external support or without external support, the heart will function on its own for many years. But during this resuscitation, if a significant time period had lapsed, the brainstem gets damaged permanently, the respiratory center is lost permanently, and the patient is not able to breathe. We are able to maintain the respiration through an ET tube and through a ventilator, but as on date, we are incapable of making that patient breathe again on his own. We can use a ventilator with heart function on its own, but the respiration is not happening. It doesn't happen. We cannot make the patient breathe again. This is a big mismatch between the cardiac and the pulmonary resuscitation. And this exactly led to a situation where patients were in permanent coma. So dead or alive, life is pleasant, death is peaceful. It is the transition that is troublesome, said Isaac Asimov, a Russian-born US writer. It is true because dying today has become a process. So somebody gets admitted in a hospital, has an arrest in the ward, code blue initiated, patient taken to ICU, put on the ventilator, resuscitated, and continues on, and where is the end point? Today, we are permitted to die only when CPR is not given or withdrawn, or ECMO is not provided or withdrawn. We have reached a stage where everybody goes into a process of dying and without an endpoint. So at some point of time, when it has become irreversible, and we all know that life is not going to be propagated, how much ever we continue to resuscitate these particular patients, it is not a diagnosis anymore. Today it has become a decision which the intensivist or the physician has to sit with the family members of that person who is in an irreversible coma and take a decision at some point of time. So because of this situation, endlessly patients were being maintained on ICU care, and it led us to a compulsion to redefine death, because on one side, these patients are not going to have any recovery and endlessly will be resuscitated, and they are occupying resources which could be given to patients who had a better chance of survival or who had a chance of survival. And on the third side, we have demonstrated to the world that organ transplantation is a possibility, it is successful, and these patients potentially can donate organs because of their permanent brainstem damage, and patients who are in need of organs could lead a good quality of life. So because of the technological advance today, events that were linked to death in the past, like absent pulse rate, absent blood pressure, absent saturation, that are all no longer valid. The concept related to death of all organs at a particular point of time is no longer valid today. Patients who have a beating heart, who have a recordable blood pressure, who had a recordable pulse rate, they've all been declared dead because their brain has permanently stopped function. But at the same time, these things, the presence of absence of vital signs, clinical death is not sufficient. A patient with working heart can be pronounced legally dead today. As scientific knowledge and medicine advanced at a rapid pace, it was more and more getting difficult to formulate a precise medical definition of death. But at the same time, we should look at the dilemma or the challenges which we have, because these patients can fight infection, they micturate, they defecate, they fight infections, their wounds are healing. Somebody who had undergone a craniotomy for head injury, even though he is brain dead, 5th day, 6th day, you will find that the wound has healed well. And more importantly, brain dead patients who are pregnant can continue to gestate and still deliver an alive baby. So can we consider them as dead? That is a big challenge and dilemma which we face. If you consider the earliest reports of brain death, it was Maimonides, a rabbi scholar and physician in the 12th century. In those days, decapitation was a form of punishment. So we can wonder, when somebody is decapitated, which is the precise moment of death? Because the body will throw around itself, the blood will still pour, the heart will continue to pump for a few minutes or seconds. But when is that particular person died? So Maimonides, it was during these punishments, it was mandatory for the presence of a scholar or a physician. And he found that at the moment of decapitation, the patient stopped breathing. The blood is pouring out, right, is throwing around, limb movements are present, but they stopped breathing. And he for the first time proposed brain, by way of controlling respiration, should be considered as the central organ as far as the defining moment of death and life is concerned. And his statement, his finding was validated almost 800 years later by the French physicians Mollaret and Gaulan in the year 1959. So the physiology of death today has revised. Can be a primary or secondary brain event can cause death with a beating heart, primary or secondary respiratory event leading to cardiac circulatory arrest, or primary or a secondary cardiac event that results in cardiac arrest and circulation. But whether the cardiac circulation is present or not, when the brain circulation is arrested, the patient does not have a possibility to regain identity or survival. In other words, a patient with arrested cardiac circulation becomes dead because his cerebral circulation also gets arrested, and it is not the other way around. So the defining moment is absence of cerebral circulation, not anything else. So today, CPR, ECMO, these have divided the historical concepts, and death only today if CPR or ECMO is either discontinued or provided at the basis. So with this, we all can understand that brain is the central organ which has to define the moment of life and death. So coming to this is the basic concept of brain death, that somebody cannot breathe, we cannot make them breathe. As on date, we are incapable of that if the respiratory center is permanently damaged. So where do we see such patients? These patients have to be in an ICU. They have to be in a ventilator because they are not able to breathe on their own. And once we see such patients, we should have a neurological cause. There should be an imaging finding, neurological cause. We should do a brain imaging, a CT brain or an MRI as the case may be. And the finding that is present in the scan should correlate with the neurological status of GCS3 of the patient. And these patients do not need sedation. They do not fight the ventilator. They tolerate the ventilator for a long period of time. So these patients have severe neurological deficit damage with the way of GCS 3/15. The next important aspect is do a scan. The finding of the scan should correlate, should tell us that yes, this patient could be brain dead because of these extensive findings in the scan. They do not have, the pupils don't react, they don't breathe on their own. Many of them have diabetes insipidus. Most of them have cardiovascular instability and require vasopressors to maintain their blood pressure. And the most common etiology in India is trauma, head injury, followed by stroke and aneurysmal rupture. But whereas in abroad, the disciplined traffic is so heavy that it is very, very negligent that we have patients with trauma who become brain dead, and it is mostly the neurological, hemorrhagic, stroke and other conditions that leads to brainstem. And these are some of the scans. You can see this acute subdural hematoma, extensive parenchymal bleed, extensive injury, diffuse subarachnoid hemorrhage, and these findings, yes, are consistent with the neurological status of a clinical brain dead patient. So once we establish that it is neurological criteria, that yes, we have an extensive finding in the scan that can contribute to the neurological status of this patient, then we move on to examining the brainstem reflexes. There should be no response to painful stimulus. Pupil should be dilated and fixed. The Dalsey or oculocephalic maneuver should be negative. We should perform a calorie test in both the ears separately. That should be absent. We should examine the eye. The corneal conjunctival reflex should be absent. Cough reflex should be absent, and they should not have spontaneous respiratory effort. So to be very clear, the painful stimulus should be given in a cranial nerve distribution, not over the sternum or anywhere else. It should be within the cranial nerve distribution, and mostly the supraorbital ridge is where we give and there should not be any movement of the facial musculature or the limbs when pain is being given at this position. The patient can have indeterminate movements when it is given in the non-cranial nerve distribution like the sternum or the arm or the nipple or anywhere else. These are indeterminate movements. So limit yourself to give this painful distribution, painful stimulus only within the cranial nerve distribution, and the pupillary reflex pupil should be dilated and fixed. Then you have the oculocephalic reflex, which also should be absent. The Dolce maneuver is absent. We do calorie test each year separately. Wait for at least 1 minute to see whether there is an eye deviation or not. If the eye is not deviating when the calorie test is done on both sides, then that test becomes negative. Do a corneal reflex, test for the conjunctival reflex, it should be absent, and test for the gag reflex. Cough reflex is absent. You put in a suction through the ET tube, the patient does not have any. Again, I tell you, all these things are within the cranial nerve distribution up to 12, not within the spinal reflex arc area, because yes, almost 30% of patients can have indeterminate movements when they are stimulated in the spinal dermatomal region. So now we have a set of yes questions. Etiology known, yes. Is can correlating, yes. Toxic causes like alcohol, sedation, and muscle relaxants are not present, yes. Metabolic parameters, I'll tell you the parameter range. Within range, yes. Core temperature is above 35 degrees centigrade. And there are certain no questions. No alcohol intake in the last 6 hours, not on sedative, not on narcotics, no muscle relaxants have been given in the last 6 hours, and the brainstem reflexes, which I have already mentioned, they are all absent. So we have a situation where patient is in GCS3, no respiration, image correlating with the clinical status, all yes questions have yes as answers, all no questions have no as answers. As I mentioned earlier, we can have these indeterminate movements either spontaneously or when stimulated within the spinal. The spinal, it is the brain that is dead, but the spinal reflex arc is still working, and it does not have the superior control of the brain or the spinal cord. It is acting on its own without any superior control. So 1/3 of patients can exhibit the spinal reflex arc movements. They can have finger jerks, the undulating toe flexion sign where you have this toe flexion, triple flexion response like a dorsiflexion, knee flexion, and hip flexion. Abdominal reflexes may be present. You can have the deep tendon jerks, plantar sign may be present, and sometimes the Lazarus sign where there are extensive movements. And I'll show an example of one such patient. This was a patient recently we had. Spontaneously, there was movement of the limbs. And the toe movements were also present. But this patient was clinically brain dead. We did do apnea test, which was positive, and he was a very good donor. We transplanted 7 people from this one. And this needs a bit of experience to differentiate between whether these are indeterminate movements. So they can occur spontaneously or when painful stimulus is given away from the cranial nerve distribution. If such thing happen when the pain is given in the cranial nerve distribution, then that should not be considered as clinically brain dead. So when will we not defer certifying somebody as brain dead? When the brain imaging is normal, patient has fever, he is hypothermic, pinpoint pupils, myoclonic jerks, or patient has rigidity, or the lab values, the sodium, potassium are outside the range, and when there is a drug screening for sedation and other things positive. So now we have reached a stage where we can perform the apnea test, because the yes questions, no questions, all of things are right. Then we go to the apnea test. At the time of apnea test, identification is completely clinical based on imaging, based clinical absent brainstem reflexes. But when an apnea test is done, the metabolic parameters should be within this range. If they are outside this range, it is our duty to correct these parameters, bring them within this range. Only then we can do an apnea test after 6 hours. But if it takes 12 hours for the parameters to come within this range, or 18 hours, we can do it at that time only. When it is outside this range, apnea test should not be performed. So pH is 7.3 to 7.45, glucose is 60 to 360, sodium is 120 to 160, potassium is 2.5 to 5, PO2 should be more than 75, and PCO2 30 to 45. When it is within this range, we are safe to proceed with an apnea test. If it is not within this range, we cannot proceed with an apnea test. And the vitals, the core body temperature, the systolic BP should be more than or equal to 90, or if you choose to follow the mean arterial pressure, it should be consistently about 60 millimeters of mercury. So once we have the blood parameters are within range, what we do is we give FiO to 100%, hyperoxygenate the patient for 10 to 15 minutes. We slightly underventilate the patient. We reduce the minute volume so that we allow the carbon dioxide to build into the blood to somewhere around above 40. And after disconnecting, we give oxygen through a suction catheter at the rate of 5 liters per minute. Do not go above 5 liters because the lung is in full positive pressure ventilation. Giving high flow oxygen may cause rupture or bullous rupture or pneumothorax. So first test is usually done 6 hours after the patient has become clinically brain dead. Only when the parameters are within range. It may be 12 hours, 24 hours. We may never be able to do an apnea test. The parameters don't come within the range. So we take a baseline ABG, and the ABG, the PaCO2 should be somewhere between 30 to 45 with a pH range, as I mentioned already. So now we disconnect the patient from the ventilator. The only thing which we are looking at is whether the patient is able to breathe on his own. One spontaneous respiratory attempt. So we look for the respiratory attempts. There can be Lazarus movements, indeterminate movements, but the only point we are looking at is whether the patient is making that one respiratory attempt spontaneously. So usually we do it for 10 minutes. If for some reason you decide to abort the test after 6 minutes, you can take an ABG. And then based on the ABG, we decide about the result of the apnea test. The duration between the two tests is 18 years and above is 6 hours between the first positive apnea test and the second test. For a 31 days old baby to 18 years, it is 12 hours between the two tests. And term newborn to 30 days baby, it is 24 hours between the two tests. And there is no consent needed to do an apnea test. So when you are doing the apnea test, what are the situations you will abort the test? When the systolic BP for every minute we see, every minute somebody calls out. As I look for the respiratory attempt, somebody tells me pulse rate is this, blood pressure is this, saturation is this. So every minute we see, and when the patient has a systolic BP below 90, significant cardiac arrhythmias or a saturation below 85, we abort the test. We do not continue. But if 6 minutes has elapsed when you want to abort, you can still take an ABG, and that ABG can be considered as a post-apnea test, even when you abort. And if it becomes indeterminate or you cannot certify, an aborted test can be repeated after 3 hours. So when is the apnea test positive? Patient did not have a spontaneous respiratory attempt, but the post-apnea ABG, which we took, the PaCO2 is more than or equal to 60. Then you need not look at any other values. It is a positive apnea test. If it is not above 60 and above, for example, let us assume we started the test as 32 PaCO2. The post-apnea PaCO2 is 56. Then that is a 24 difference. So when there is an increase of 20 or above from the baseline to the post-apnea, that also is considered as positive, even if the value is not 60 or above. So these are two situations where you declare it as positive. Negative, when the patient has taken one spontaneous breath, it is considered as negative apnea test, and the test should be abandoned immediately. Once the test becomes negative, it can be repeated only after 24 hours, not at any point of time, only when the clinical grounds are strong enough. So when is indeterminate? The patient did not breathe throughout the apnea test, but the rise is insufficient. Let us say we started the test as 32. The post-apnea value PaCO2 is 48. There is only a difference of 16. It is not beyond 60 also. So this test is not positive, not negative because patient did not breathe. So this is considered as an indeterminate test. And again, if clinical grounds persist, you can repeat an indeterminate test after 3 hours. So when will you certify somebody as brain death? When all these criteria have been met, absent brainstem reflexes, 2 apnea tests are positive, all yes questions have yes answers, no questions have no answers. The time of death is, be very clear, the time of death is the last ABG, post apnea ABG that was withdrawn. The patient may go in for organ retrieval, or the patient may not be willing for organ retrieval. The heart may stop 1 day, 2 days, 3 days later, but the patient is declared dead at the time of the second apnea test. You can mention in the case sheet that heart stopped at this date, at this point, this time, 1 or 2 days later or 6 hours later, as the case may be. But the time of death is always the time of second apnea test. I'll tell you why later. So red flags does not mean we should not proceed. We should proceed with caution. For example, somebody who has had a cardiac arrest, he has been revived, and it took a little longer for that revival. Here, the brain damage is because of hypoxia, not head injury, not bleed, not structural damage is not there. It is more of a functional damage. So in such cases, for example, somebody has become arrested and revived and become brain dead today 3 p.m. You will re-examine the patient tomorrow afternoon 3 p.m. That is after 24 hours. If the patient still the brainstem reflexes are absent, you can consider them as clinically brain dead. And the first apnea test will be done only after 12 hours. So it is almost 36 hours in case of hypoxia. And the same is for hypothermia. Only when the patient has become normothermic, after 24 hours of normothermia, if he still continues to have absent brainstem reflexes, the first apnea test can be done after 12 hours. And sometimes neuromuscular disorders or cobra poisoning, where you have this neuromuscular junction destruction. Reports have said even after 7 or 8 days, the NM junction has recovered. Patients have recovered. So in such situations, we cannot proceed with an apnea test because the patient is not going to breathe. So in such situations, we wait for 72 hours and then proceed with an ancillary test to certify. And anybody who has had a surgery, after the last dose, we should wait for 6 hours. And these are the cautions. So ancillary test, we have seen the apnea test, how to certify, when to certify, what is the time of death. Now, there are situations where we won't be able to do an apnea test. For example, extensive bilateral facial-maxillary injury, high spinal cord injury above C4, where the patient is not going to breathe, even if the brainstem is intact. Pulmonary edema, pulmonary aspiration, the oxygen saturation status is so low. If the FiO2 of 100, patient may have a saturation of 92, 93. The moment you disconnect from the ventilator, saturation is going to fall. So chest injury, neuromuscular disorders, as I mentioned, neurotoxins, and eye. Eye is a very, very important examination tool because for brainstem death, we examine second, third, fourth, fifth, sixth, seventh, eighth, ninth, and 10th cranial. Now only 9 of them. The first and 11 and 12 we do not examine. But when there is a severe injury to the eye, a globe injury or severe periorbital edema where we are not able to examine the eye, then we are not examining 7 out of 9 cranial nerves. We can't examine 2, 3, 4, 5, 6, 7, 8. So that is a big chunk of neurological examination that is missing. So in such situations also, we can perform whatever neurological test is possible and then proceed with an ancillary test and don't proceed with an apnea test. So these are the situations where you have this is not a diffuse subarachnoid hemorrhage. This is actually blood clotted within the blood vessels. You can see all these blood vessels, they are all clotted, which produces a hyperdense signal. So transplant today, we recommend cerebral angiogram, CT cerebral angiogram. Yes, DSA, MR angiogram also can be done. But the specificity of a CT angio is 100% with a sensitivity of 85%, which means we can never have a false positive. There may be false negative. That is completely different. We are not bothered about. But 100% specificity is there. And we look for 4 vessels. The right MC, M4 segment, left middle cerebral artery, 4th segment, right internal cerebral vein, and the left internal cerebral vein. And there should be no flow in all these 4 vessels. In that case, we give a score of 4/4. which is positive. Anything less, 3/4 or even 1/4 is negative for brain death. We should not proceed with certification. So DSA is the gold standard, but nowadays it is recommended to do a CT angio. You can see in a DSA that there is no intracranial circulation. But again, brainstem death is a clinical criteria based thing. Ancillary test is only supplementary. We have a tool that says yes, cerebral circulation is absent. But in such cases, the time of death is, we should do full set of doable neurological tests before CT angio. Patient gets a CT angio done, comes back to the ward. Immediately after receiving in ward, we should do another set of doable neurological tests. And that test, that time when we complete that test is the time of death, not the time of CT angio. And if the CT angio is negative, as for an apnea test, it can be repeated only after 24 hours if the clinical strong is doubt. So these time frames are given to give the maximum benefit of doubt to the patient. We want actually why we do all these things is not to certify him as brain death, but we are giving more than enough opportunity for the patient to tell us that he is not brain dead. Every opportunity we give time frames, we give so many things. Let that patient breathe one time, one spontaneous respiration, and tell us that I am not brain dead. That is how these tests are designed. This is to give the maximum benefit of doubt for the patient to tell us that he is not brain dead. And why is the time of death the second apnea test is because of this social order, which was proposed by Guy Alexander in 1966. He said, declaration of death in a person before starting organ procurement should happen, or organ procurement cannot result in death of anybody. In other words, yes, renal transplant is possible in living donor, but can we donate our heart? Can we donate our lungs? We cannot. It is suicidal, and whoever is retrieving the organ is like killing the patient, and that is against the Hippocrates oath. So that is the reason. A person cannot become dead because he has donated his organs. So we declare him as dead at the time of second apnea test. Only then we can go and ask for his organs to the family because he is already dead. And only then the cross clamping can be done. By declaring someone dead, we give the transplant surgeons the permission to go ahead with cross clamping. Otherwise, the cross clamping becomes something amounting to kill. So that is exactly the reason why these timings are maintained. So when will you evaluate? A patient has come in at 12 midnight, let us assume, who is clinically brain dead at that time. He can be identified only after 6 hours, at 6 a.m. in the morning, even when he is admitted in a brain dead state. And in case of hypoxic brainstem damage, as I mentioned, 24 hours after, brainstem reflexes are absent. And from the time of identification, the first apnea in case of trauma and other reasons is one. And these are special situations. How to do an apnea test in patients who are on ECMO, that is beyond the scope of this topic, and I'm not going into it. The examination of eye, the importance of which I have already mentioned. And when there is an unequal pupil, do not proceed with the certification based on clinical criteria. Please do an ancillary test because it may be a primary brainstem injury that has caused this clinical status, and we do not know whether the circulation is present or absent. These are mimics of brainstem death. Likewise, when the primary problem is in the posterior fossa, a cerebral or intracerebral hematoma, a brainstem bleed, a pontine hemorrhage, blood in the fourth ventricle, or when someone has hydrocephalus, we do not know whether the patient is clinically brain dead with an arrested circulation. These things can mimic brain death. So when we perform an apnea test, it may be falsely positive. It may be falsely positive. So these are special situations. In such situations, we should do an ancillary test, objectively demonstrate that the cerebral circulation is stopped, absent. So don't proceed with apnea test in such situations. And of course, when somebody is pregnant, it depends on the viability of the fetus. Today, we say 20 weeks is viability, 24, 26, there are so many things. So when somebody is pregnant and brain dead, it becomes the family's decision. Whether they want the child or not, viable child, that is the biggest question. If the family decides to proceed with organ procurement, may not need the child, and we have to do an hysterectomy, proceed with organ retrieval, and if the child is surviving, we need to give it to a child welfare committee or the home. Or if they're not willing for organ donation, then that is a different question. The fetus also succumbs along with the mother. These are special situations which we have to look at and be very careful in taking decisions in such times. This is where experience helps, and constantly discussing with other people who are routinely doing brainstem death certification also helps. And caution, in children, the ancillary test has limited data. So we predominantly rely only on the apnea test. We are very hesitant to do an ancillary test, particularly in the pediatric population, because they have not yet been validated. So purely rely on apnea test. So recently we had an 18-month-old boy who came from Andhra Pradesh to MMC, RGGGH, and he became the youngest donor in the whole state. And we did 2 apnea tests. We didn't proceed with angiogram. Initially, it was very difficult to maintain him with high sugars and other things. Somehow we managed, and he became the youngest donor. And we cannot decide who can be a donor and who cannot be a donor. Let me tell you, age is not a criteria. Today, HCV positivity is not a criteria. HBsAg positivity is not a criteria. HIV positivity is not against painter. There are recipients who are HBsAg positive, HCV positive, HIV positive, who are in need of organs. So it is not for the certifying team to decide who will be a good donor, who will not be a donor. Our job is to certify mandatorily when somebody is brain dead. It is for the transplant surgeons team. Even recently, we have seen a patient who was willing for organ retrieval. One of the kidneys had an RCC, renal cell carcinoma. It was biopsy proved. A partial nephrectomy was done, and then they proceeded with renal transplant. It's been more than 3 years now. Patient is surviving. So please, my humble request, do not decide about the graftability or the suitability of someone to be an organ donor. Our job is restricted. My job is restricted to certify someone as brain dead. So if you look at, he is the oldest donor globally. He was 95 years old when he donated his liver. And incidentally, his son 10 years earlier was also an organ donor. So 95, the recipient is doing very well. As far as India is concerned, the oldest is an 85-year-old man who has been a donor in Mumbai. And recently we had a 78-year-old lady whose kidneys were transplanted to a 51 and 41-year-old, and they are doing well. And in MMC, RGGGH, where I work, we recently had a 72-year-old organ donor who gave life to 7 people, and they are all doing well. So it is not based on the age. Do not think he is not a suitable donor. And what is the life of these transplant recipients? We do have the transplant games. This year it is scheduled to happen in Chennai. Last year, Kochi had the first transplant games where the transplant recipients and living donors, they are participated. It was inaugurated by Mammootty here, and people won. And the badminton was won by a lady who had received 2 renal transplants. So remember, for us, for a donor, for a recipient, for everyone, life is there even after somebody has become brainstem death. He can continue to live. 1,000 kidneys donated means, yes, 1,000 renal failure patients have benefited, but 1,000 healthy patients were not operated upon. 1,000 healthy patients need not undergo a major surgery to donate an organ. They can be healthy, and today we know living renal donor is safe is not absolutely correct. There are a lot of records and studies which comes out based on the living donors who had given one of their kidneys. The rate of renal failure is slightly higher on them, hypertension and so many other aspects. It's not absolutely safe. Maybe in future we will have more, and this is the social responsibility of our physicians, because if you Google the word kidney Vakam, you will find out it is our own Willy Vakam, where you can buy a kidney for 25,000, 40,000 rupees. And if you see, 95% of these donors were women. the head of the family would have donated the kidney of his mother, wife, sometimes the daughter also, and would have drank well. Nothing would have happened. So this is one of the trigger which prompted the government to go into a transplant and develop a fully robust program. And I feel this is our social responsibility. So at this juncture, I'm winding up now. I gratefully acknowledge the extremely dedicated neuroconsultants, the intensivists, anesthesiologists, the entire transplant team, the administration, and the contributions made by all the patients, and more importantly, the relatives who took that noble, valiant, gallant decision of the organs of their disease during their time of grief and bereavement of losing their loved one. So the need of the hour today is passion and social responsibility among the physicians to certify someone as brain death. So to conclude, we have looked at the physiology, the concepts of death, why brain is considered as the central organ, and why brain death is equivalent to brain death. Yes, we need an uniform decision, but at the same time, when there are special situations, we need to individualize our decisions for that particular patient. It is a passion, it needs passion, it is a teamwork, and the basic word which defines this entire act is altruism. So how to keep this burning? We are physicians, transfer the flame, and very important, one candle can light so many other candles and the flame continues to burn. So these are my references, and thank you so much for giving me this opportunity and the patient listening. I'm indeed feel privileged to be a part of this wonderful program organized by IMA, and I thank my special thanks to Dr. Rajesh Babu, Secretary of TANS and Chairman of the Brain Death Committee, IMA. Thank you so much, sir. Thank you so much. Thank you. I'd be happy to answer if there are any questions.
Yes, sir. So it was a very nice discussion which was given by Dr. Raghavendra sir about the brain death certification. An exhaustive lecture which was given by Professor Raghavendran sir. Now I request our participants to ask the questions.
Sir,
Dr.
this is
Sundaramurthy has put one question.
yes, sir. It's Dr. Sundaramurthy from South Chennai IMA.
Yes, sir.
It's only academic question. Is the stem cell therapy a challenge to the organ donation?
No, sir. Stem cell therapy has not yet been proven to be of anything. But on the other hand, what I wish to tell you is, sir, this is neurological criteria of brain death. And the patient has a image finding that correlates with the clinical status, a massive subdural hematoma or an intracerebral hematoma. And this is not something like a diffuse axonal injury or anything else where we can administer stem cell therapy. Stem cell therapies are given to patients with a functional loss. They are not in a clinically brain dead status, sir. So
Yes,
this
yes.
is neurological criteria of brain death, not based on anything else.
So one more basic question is the organ donation.
Yes, sir.
The outcome regarding rejection and all is more in the male or female?
Sir, it is not so, sir. Actually, it is the graftability that decides all these things, sir. So it is our duty when somebody is clinically brain dead, whether they proceed to organ retrieval or being a donor, it is our duty to maintain the donor in such a way. We should consider everybody as a donor. That is one thing, sir. And
Yes,
there
sir.
are other things like comorbidity and other factors which
That's
also
right.
to these questions. And post-operatively, they have to be on continuously immunocompromised status, which costs much. Yes, the government is giving it free of cost now. There are so many other factors which lead to this rejection syndrome, sir.
In
Apart
male
from,
and female. Male and female, no difference.
it's not much of a difference, sir, actually.
Oh. Thank you, sir. God bless you. Thank you.
Sir,
Well
sir,
done.
I was your student as UG, sir, in Ward 12. You were assistant professor at that time in Professor
Thank you.
A.S. Sir's unit.
New building has come. New building வந்துச்சு.
Yes, sir. இப்பதான் inaugurate.
Separate கொண்டு வந்துட்டாங்க.
Yes, sir. I am
Very good.
director
Thank
of
you.
neurosurgery now.
Yeah,
Windows
fine.
has inaugurated. Yes, sir. Thank you so much, sir.
God bless you. Thank you.
Thank you, sir.
Good evening, Dr. Raghavendra. I have a point to add.
Good evening.
We maintain them basically with the Rylstib on with Eltroxin. It can vary about 150 to 300 mics to maintain the BMR, though he is brain dead, number one. And second thing is the electrolyte balance. If it goes beyond 3 days, they go for a muscle being flabby and there'll be hypernatremia. The Riles tube, if there is a hypernatremia, we have to put through the Riles tube, we have to give water around 10 ml every hour to bring down the sodium levels.
Yes, ma'am. Thank you, ma'am. Regarding thyroxine, ma'am, the main role of thyroxine has been it potentiates the effect of ionotropes in maintaining the blood pressure and hemodynamic status of the patient. That is the main use of thyroxine. And it has always been controversial. And in recent times, there is clear-cut scientific evidence that it may not be useful. And today, we have decided it can be administered based on the justification
That
of
also maintains the body temperature, sir.
Yes, ma'am. Only when the first apnea test becomes positive.
Positive.
The methyl prednisolone also, it is the same way. And the major cause of hypernatremia is actually diabetes insipidus that sets in early because of the pituitary dysfunction and somebody becomes clinically brain dead. And there are so many ways of maintaining this. So we can continuous infusion of half normal saline. We give this free water and so many other things. We have an entire donor management cell today at MMC. We take care of all these things and maintain the donor.
You
Yes.
remember we used to declare the brain dead by EEG. Way back in 14, 15.
ஆமா மேடம் அதெல்லாம் 2017
அதெல்லாம் போய் இப்ப we have moved somewhere else.
நம்ம பண்ணோம்.
ஆமா.
Today we have stopped doing EEG. We have stopped this now conduction study. It is only vascular based, circulation based வந்துட்டோம். Because there has been
DSA latest.
CT angio இப்ப நம்ம பண்றோம் மேடம் நிறைய. In
And
fact, MMC
DSA.
is the first center in the whole country with certified brain death based on the CT angio criteria. We did that around 15, 16 months ago, madam. Madam, so nice talking to you. I never understood you are in the audience. We have worked lot of time in MMC.
Lot of time till August. We have done some 19 cases which fetched me an anesthetist award for transplant.
Yes, ma'am. Last year we did 26. And
Way back in 2017, I got an award.
Yes, ma'am. And today in 2024, till now we have done 9 in MMC.
Yes, they were discussing that in the Dean's meeting.
Yes, ma'am.
Thank you, Raghavendra. Nice talking to you.
Pregnancy continue for a few weeks in spite of brain death.
Yes, sir. If the patient's family wants to have the child, then we have to maintain the patient dynamically. And generally what is being done is it compromises the fetus, however much hemodynamically you maintain. So depending on the viability of the fetus, if the fetus is viable, it is better to go ahead with a section, take the child out and take care of it rather than continue someone. If the viability has not yet been reached, then yes, it is justified in continuing to maintain the pregnant lady until the fetus becomes viable. Thank you, sir.
So regarding the brain death certification, only the vascular study only is now followed, or how other centers are following it up, sir? Your idea?
No, sir, actually it has been proved beyond, because this now conduction studies, EEGs, they have lot of ambiguous activities. So they are not foolproof. So it is mainly based on the vascular criteria of ancillary test. That is what we do today. And CT angio has 100% specificity and DSA is the gold standard. CT angio is more than enough. So all ancillary tests we have brought into one umbrella of vascular, establishing absent cerebral circulation objectively.
Sir, in CT angiogram, there will not be any vascular marking at all.
No, sir. CT angiogram, we look only at 4 vessels. See, the large vessels, when the blood inside the vessel gets clotted, at some point of time, it is bound to lyse. So the force with which this contrast is being injected, you may find a faint amount of contrast into the larger vessels. So we don't look at the internal carotid, middle cerebral or other things. We look at the 4th bifurcation of middle cerebral artery, right side and left side. That is M4 segment of right and left. And the most specific sign is absence of circulation in the internal cerebral vein, right and left. So these are 4 vessels which we look into it. And when flow is absent in all these 4 vessels, we give a score of 4/4. And 4/4 indicates brain death. 3/4, 2/4, 1/4 is not brain death. So we look at only these 4 vessels. Previously, we had this 10-point scoring system where we included the basilar artery, posterior cerebral artery, and we had the 7-point scoring system. We had the bilateral A3 also involved, included along with the vein of Galen. But today it is only these 4 vessels. It is the cortical branch that actually supplies the brain parenchyma that is looked into.
Sir, I like to know that it is being done in Chennai in your institute, but
Yes.
the rest of the people are following it or not. Any information about that, sir?
Sir, most of the centers have now started following it. And in fact, some centers, some private setups, they do both apnea test as well as the angio, because it is objective. That is their argument. And yes, sir, now it is slowly picking up, because we have given the clear-cut guidelines. It is published in the Transstan website, the guidelines we have given. So that mentions CT angio as the recommended ancillary test. Yes, sir, many centers, even before these guidelines, some centers used to do both the DSA as well as apnea test.
Now I request our panelist, Dr. Saravanan sir, Dr. Tirumurthy sir, and the other panelists, the transplant coordinators, the Balakrishnan from Royal Care, the Rati from PSG Medical College, and Ashok from Ganga Hospital, and Devi from KMCH. If you have any doubts to ask to Dr. Raghavendra sir, you please ask. Dr. Saravanan sir and Tirumurthy sir.
Sir, good evening. This is Dr. Saravanan. I'm the nephrologist placed in Erode.
Good evening, sir.
Good evening, sir. As a nephrology point of view, and I am the present IMA president of Erode. What I think is this brain death declaration is not happening widespread, and many patients in ICUs who would have been brain dead, but would have not been declared so. So there is a very high hesitancy in many intensive care units across the state to declare a brain death, and apnea test conduction itself. Many today you have very clearly cleared the doubt of not requirement for a consent to do apnea test. And many ICUs were not actively doing this apnea test. And because from a nephrology point of view, it is 40,000 more patients are on the wait list, active wait list. So they have been getting registered into the wait list, and many of them die without getting an organ. That is the present sad scenario in Transstan. But Transstan, we have to wholeheartedly congratulate that being the 6th to 7th time, Transstan has been the highest record for doing the cadaveric organs transplants. And the transparency that is there inside Transstan's organ allocation is uncomparable to other states. And I have personally added a donor on our setup, and then followed up the process, and we have also trained our coordinators to do the job. But we don't know how to overcome this hesitancy to do apnea test and declare brain death in a patient in ICU setups. This is the first hurdle that Indian Medical Association, having the state president and state secretary in this meeting, I will advise that further this Zoom meeting, in continuation with the Zoom meetings, maybe if Rajesh sir is very actively doing this Zoom meeting, and we have to appreciate his efforts on this, if possible, to conduct some CMEs in IMA, that is the IMA. Every IMA of every district has some monthly meetings, and if a team of this organ donation committee extends this awareness in getting this brain dead declaration, only then the donation rate might increase. And I should also pinpoint the fact that no patient should be declared brain dead just for the sake of organ harvesting. So, that is why you have been educating us that we have to wait for 72 hours, etc., etc. And as a nephrologist, I would pinpoint one thing, that if there is gross dyselectrolytemia, as you told, the sodium level should be within that set range for us to use this apnea test as a brain death declaration modality. And sometimes we may need to, this is one question to you, sir. Do you advise levothyroxine infusion in brain death individuals if the apnea test is going to be indeterminate, something like that, sir?
Sir, yes, sir, nice told. Just see, actually, several studies state that in all major cities, there are at least 8 to 10 clinically brain dead patients at any given point of time, and they are not identified. That is purely because of the reluctance of the neurophysicians and the neurosurgeons and the intensivist also. So government has made it mandatory, and slowly things are picking up, because last year we had 174. And this year already we are close to 50 in Tamil Nadu in 2024. February has not yet come to a close. So it is slowly picking up. Yes, it needs a passionate person. Everywhere it is being run on the passion of that neuro specialist who takes care of it. And the moment he leaves that particular hospital, then whoever comes to take care, then there is a dip in what is happening. That is a social responsibility under this one. And this triad of thyronin, sir, recently the studies are not giving conclusive evidence that the main idea was to potentiate the effect of ionotropes on the hemodynamic instability. The presence of thyroxine makes it more, potentiates the action of the ionotrope support. And there are not clear-cut evidences today. We have, as per the transplant guidelines, we have permitted the use only after the first apnea test becomes positive. And this electrolytemia, yes, it is a big challenge sometimes. See, most of the patients which we see, they are stable. They don't need any more corrective measures are not needed. They remain as stable as that until they go to retrieval. Some patients, yes, they develop, and it becomes very difficult to manage this and that, the magnesium, which to give. Potassium is on one side, sodium is on one side. Yes, it is a big challenge to maintain these donors. And there need to be an exclusive team to manage the donor the moment we identify someone as clinically brainstem dysfunction. And yes, sir, awareness needs to be more. It is slowly picking up, but needs a lot to be decided.
As one more practical advice to all the other persons in the Zoom meeting, sir, as being me as nephrologist, I cannot even touch the case sheet of the donor. Actually, the recipient management team should not even put one single notes in the donor's case sheet, which may not be happening in some areas. So this is what I want to pinpoint. As a nephrologist or a liver transplant surgeon, will not be even given that liberal chance to put notes on the donor maintenance, because all this levothyroxine infusion and sometimes the urine output might be very high, requiring a vasopressin infusion, etc. All those things will be necessary, but as per the advice and legality, we should not even put a notes there. And what I will recommend is, even last month when I met Dr. Abul Hasan sir, State President in Erode IMA building, I was discussing this fact with him. Why not we recommend to the government that all driving licenses should be incorporated with this donor card. Actually, this has been done in some Western countries, wherein totally getting the unrelated donations to zero. Yes, by getting a successful cadaveric transplant program. If a cadaveric transplant program has to be successful, the donations by brain death has to be more, and certain Western countries have incorporated that driving license being given that acceptance towards their donation after they are being brain dead. Why can't we suggest this thing from the organ donation committee of IMA towards the government fraternity to take some steps? What is your opinion on this, sir?
Sir, actually, regarding the driving license, it has already been done. Even my driving license has it. People who have recently renewed their driving license, there is definitely a question in the application form whether you are willing to be a donor or not. It is mentioned in the driving license itself, yes or no, and it comes under the mandated donor system. But whether we have a donor card, whether it is present in the driving license, whether we are willing, it does not come into the picture at all when the decision is being taken. The decision will be taken only by the family, and whether it is present in the donor card or driving license does not matter. What we need to do is, yes, apart from putting these things in, we have to educate our family that if such a situation arises, then you please give consent for my organs to be donated. Because basically the same question, January, we had a meeting at Noto. The question was put for me was, I handled the ethical and legal consideration of organ donation. The first question put for me was, I spoke on that, is India ready for an opt-out system? Basically, India is an opt-in system where the family has to give consent when somebody becomes brain dead. Opt-out system is when somebody is alive, he should have made a legal document that he is not willing to be an organ donor. If the document is not made, becomes clinically brain dead, the family does not have any say. He is presumed to have consented for organ donation, and that is how the opt-out system. Soft opt-out system is in Spain, and many countries have gone for opt-out system, including Singapore and recently Wales. So these are all mandated systems. The family actually gives approval for organ retrieval in case of an opt-out system. But we are in an opt-in system, and we have decided in Noto that we are not ready for the opt-out system, at least for the next 10 years. That is one thing. Driving license, yes, it has, sir. Anybody who is renewing their driving license now, for the past more than a year, yes, it is mentioned there. It is mentioned, but that does not have any role. No donor card has any role. It is only the family that can decide at that time whether to go ahead with the organ retrieval or not. Our wish does not hold there at all.
Sir, it is an opt-in system only, no, sir?
நம்ம இருக்கிறது opt-in, sir. Opt-out போலாமான்ற question was asked in Noto. So we had a recent meeting, all over India meeting. I had been to Delhi. So we decided we will continue with opt-in system, not switch over to opt-out. இப்ப இருக்கிறது நம்ம opt-in தான், sir. Family consent.
Actually, வந்து இந்த டிரைவிங் லைசன்ஸ்ல வந்துங்க சார், அந்த கொஸ்டினர் ஃபுல்லா எடுத்து நம்ம படிச்சோம்னா அந்த அப்ளிகேஷன் ஃபார்ம்ல லாஸ்ட் கொஸ்டின் இருக்குங்க சார். இப்ப ஆக்சுவலா வந்து மோஸ்ட் ஆஃப் த பீப்புள் ஆர் அப்ளையிங் த லைசன்ஸ் த்ரூ தி ஏஜென்ட்ஸ் ஒன்லி சார். ஸோ கொஞ்சம் பேர் தான் வந்து டைரக்டா அவங்கவுங்கனே அப்ளை பண்றாங்க. ஸோ சரவணன் சார், இப்ப நீங்க கேட்ட கேள்விக்கு வந்து முக்கியமான பதில் என்னன்னா, தி லைசன்ஸ்ல வந்து அது என்ட்ரி பண்ணிருக்கா இல்லையா அப்படிங்கிறது தான் கொஸ்டின். ஸோ அதுல வந்து லைசன்ஸ்ல வந்து அப்ளிகேஷன்ல வந்து லாஸ்ட் கொஸ்டின் வந்து அபவுட் தி டிரைவிங் லைசன்ஸ் தான் இருக்கும். ஆர்கன் டொனேஷன் இருக்கு, எஸ் ஆர் நோ அப்படின்னு சொல்லி ஆப்ஷன் கேட்டிருப்பாங்க. ஸோ அதுல வந்து பெட்டர் டு கிவ் எஸ் ஆப்ஷன் சொல்லி ஃபர்ஸ்ட் வந்து நம்ம வந்து மக்களுக்கு வந்து சொல்ல வேண்டியது வந்து, எல்லாரும் வந்து டிரைவிங் லைசன்ஸ்ல எஸ் ஆப்ஷன் கொடுங்கன்னு சொல்லி எல்லாருக்கும் ஒரு மெசேஜ் ஸ்ப்ரெட் பண்ணணும். அதே மாதிரி இந்த டிரைவிங் ஸ்கூல்ஸ் எல்லாம் இருக்கு இல்லைங்களா, அவங்க தானே மெயினா வந்து ஃபில் பண்ணி பண்றாங்க. ஸோ அவங்களுக்கெல்லாம் சொல்லி இந்த கொஸ்டின்ல வந்து எஸ்ன்னு சொல்லி சொல்லுங்க. இந்த கொஸ்டினை வந்து எல்லாருக்கிட்டையும் பணம் வாங்குறதுக்கு முன்னாடி இந்த கேள்வி கேட்டுட்டு அதுல என்ட்ரி பண்ணுங்க அப்படின்னு சொல்லிட்டு வி ஹாவ் டு டெல். தட் இஸ் த மெயின் இம்பார்ட்டன்ட் திங் சார். ஸோ அதே மாதிரி இந்த இதை வந்து அந்த ஆப்ஷன் கூட ஆக்சுவலா கொடுக்காம கவர்மெண்ட்லயே வந்து டைரக்டா வந்து லைசன்ஸுக்கு வந்து ஒன் ஆஃப் த கிரைட்டீரியா டு மேக் எஸ் அ லைசன்ஸ் இஸ் டு பிகம் an organ donor சொல்லி அதை இன்க்ளூட் பண்ண சொல்லி we have to recommend to the government, sir.
இல்ல சார், அப்படி பண்றதை விடவும் only people who have registered as organ donors are eligible to receive organs. அப்படி ஒரு mandate கொண்டு வந்தீங்கன்னா then I think that will have more value. You can be an organ, உனக்கு organ தேவைன்னா உனக்கு கொடுப்போம். Only when you have already exercised an option that you are willing to donate. அப்படி ஒரு ஆப்ஷன் கொண்டு வந்தா that will have more validity. More people will be willing, because I have seen பயங்கரமா இந்த ப்ரோக்ராம்க்கு அகேன்ஸ்டா பேசின many doctors at a later point of time அவங்களுக்கோ இல்லை அவங்க ஃபேமிலிக்கோ ஆர்கன் தேவைப்படுதுங்கும் போது இத மாதிரி ஒரு பிரமாதமான ப்ரோக்ராமே இல்லைன்னு அப்படியே மாறினான். I think that is also one thing. Only for people who have already pledged their organs. Later, அப்ப அவங்களுக்கு தெரியாது. Later, when they are in need of organ, I think those are the people who should be given priority. That's what I feel. That will have more validity.
On the priority listலயும் ஆட் பண்ண சொல்லி கேட்கலாம். That also we can do it.
ஆமா, priority listல pledge பண்ணவங்கள ஆட் பண்ண சொல்லி கேட்கலாம்.
ஆமாங்க சார், அந்த ஆர்கன் டொனேஷன்ல அதுதான் இந்த லைசன்ஸ்ல நீங்க சொன்ன மாதிரி அந்த லாஸ்ட் பாயிண்ட் இருக்கு. அந்த ஆப்ஷன் வந்து எல்லாருமே வந்து எஸ்ன்னு ஆப்ஷன் கொடுக்கணுங்கிறது தட் இஸ் நம்பர் 1 வந்து ரிக்வெஸ்ட் பண்ணணும் சார். That same thing we have to write it to the Prime Minister and the Chief Minister.
Educate the family, sir. அதுதான் மெயின். We need to educate the family.
Yes, sir.
Yes.
So, any other question, Dr. Tirumurthy, sir?
Yes, sir. Good evening, sir. Thank you,
Sir,
IME.
நீங்க ஏதாவது ராகவேந்திரன் சார் கிட்ட கேட்கணுமா?
Raghavan sir has put it very clearly, and he's through with this process along with the government agencies. So he is very clear. The point is very simple. In a private sector, declaring brain dead needs more precise and clear-cut definitions because it is mostly a clinical diagnosis. So these criteria, if we follow properly, I think the brain death certification should not be an issue. The point is, once it is done, the treating team should not be the persons talking about organ donation. They should move away. That's what he has also very clearly mentioned. So immediately we should get the intensivist team and the transplant coordination team. I think it is better to have transplant coordination team in the setups where organ transplants are being, which is there. But even those teams can have contacts with other private hospitals where potential donors are there. So they can coordinate and do things rather than the treating team directly getting involved in motivating people to do it. That will lead to more difficult and unpleasant situation for the treating team. I think Professor Raghavendran sir should be able to put in his thoughts on this point.
Sir, actually in MMC, what we follow is, see, counseling for organ retrieval is completely different from maintaining the patient. See,
Yes.
Our organ donor maintenance team has 2 intensivists, 1 nephrologist and a cardiologist.
Yes.
They maintain the patient. It is not that they should not be in contact with the patient. They should not make any notes in the case sheet, or it is not like that. They
Correct.
will never talk with the donor family and ask for, promote, discuss about organ retrieval and organ donation. But yes, it is ethical for a nephrologist, a cardiologist, intensivist to be still relevant, write notes in the case sheet, manage the patient as a good donor maintenance. So that is what a nephrologist is always in our team of donor maintenance, until the patient goes for retrieval. So transplant team is completely different. Nephrologists, yes, even though they are on the recipient side, ethically they can stay within that line. And yes, they are the most important people as far as I am concerned to maintain the donor. And we do it in MMC. Yes, sir.
Correct. So in our setup, we have once a patient is being identified as a patient, they are moved from the treating medical where the main person and team with them. Once things are in their favor and the patients are attentive, then they go for it. Otherwise, they maintain a problem of treating him and the other state us to be involved directly to do things and influence the decision is not going to be there. So there should be an intermediary. That's what I was trying to put in. There should be a team which is ready to, as you have rightly pointed out, you have a team.
Regarding the other panelists, his coordinators, the Balakrishnan, Rati, Ashok, and Devi, do you have any questions to ask to Dr. Raghavendra?
Sir, good evening, sir.
Balakrishnan is there?
Yes,
you
sir.
want to
I'm
ask
there,
any question to Dr. Raghavendra, sir, you please ask.
Yes, sir.
Because you are
Sir,
the person doing coordination now.
Yes, sir. Yes, sir.
You
Sir,
want to
good
ask
evening,
any
sir.
question
Good
to
evening.
Dr. Raghavendra, sir?
Yes, sir. Yes, sir. Good evening, sir. I'm Balakrishnan, Transplant Coordinator in Royal Care Hospital.
Yes, sir.
And thank you to Dr. Raghavendra. It's a very wonderful session. And thank you to Dr. Rajesh Babu organizing for this Zoom meeting, sir. And I have one main doubt. If the patient consented for organization after certifying the brain test to apnea test, the patient, the patient not consent for organ donation, shall we keep the patient in ICU? How long?
Sir, as far as our state is concerned, legally withdrawal of support is not permitted. Gujarat
Yes,
has a law, Kerala has a law where if the patient relatives are not willing for organ retrieval or organ donation, the supports can be withdrawn. They disconnect the patient from the ventilator and give it to the family once everything arrests. But in our state, it is not legally permitted. So we cannot think about withdrawing our support or anything. As long as the heart is beating, we will have to keep the patient in the ICU and continue our resuscitation. Once an arrest happens, generally brain dead patients we do not resuscitate. CPR is not. Even if they are willing for organ retrieval, before retrieval they go for arrest, we don't do a CPR. Because CPR, yes, we may be able to revive, but the graftability of the organs becomes very poor, and we should not give such an organ to any recipient. Because it is a one-time procedure, once in a lifetime procedure, we should give properly graftable organs. So resuscitation is not done, but withdrawal is also not permitted.
Yes, sir. Thank you, sir. Thank you for your answer.
Thank
Sir,
you.
one small request, sir. You please give the crisp guidelines for us to follow it up, to put
Sir, I
up
will
in
send
our
it to your WhatsApp,
time
sir.
of bulletin. Like what you have put it, you just send it up, sir.
Yes, sir.
Crisply, what is the real guidelines to be followed? Because that the message we are going to spread it to all the people. Next week, we are going to have the leadership meeting in Chennai. So in that meeting, we will put it in that thing and we will publish them. And so
Yes,
that
sir.
we will give them the guidelines, sir.
Sir, I will send it to your WhatsApp, sir. The latest guidelines
Yes, sir.
will be formulated in May 2023, actually. We had a meeting and that is the guidelines we follow. I'll send it to you, sir.
There was one question from Dr. Sundaramurthy, sir, regarding the age of the transplant, like that he was asking. Actually, the government has passed the
Pediatric
rule.
group and geriatric group, sir, cut off.
Sir, there is no cutoff, sir, as such. The oldest donor is 95 years old. The youngest
great.
donor is few days old. PGI
Oh.
Chandigarh, they recently did a 7 days old child, brain death certified and organs were retrieved.
Excellent,
The
sir.
oldest
Excellent.
donor in the world is 95 years old. In India, it is 85 years old. So these kidneys were given to 40 years and 50 years old patients. So
great.
as such, there is no age bar, no bar on any count, sir. Whether it is HIV positive, HCV positive, HBV, every category is a recipient is waiting. HBV positive recipient is waiting. HCV positive recipient is waiting. So there is no bar on any patient. The absolute contraindications are malignancy.
Yes, sir.
Severe sepsis. Apart from that, there is
Sir,
no.
one question about that is, you have asked about the person who is going to donate it. The recipient also, one rule has been passed recently, which is saying that even people above 65 years also can receive the organ. That is what the rule has come, which is being passed by Noto actually.
Yes,
That is
sir.
the rule, sir. So the both ways we have answered. One is Raghavendra sir has answered about the young age and old age donor. The recipient I am telling about from the Noto's rule actually. Above 65 years also can receive the organs, and also there is no state bar. From one state to other state you can transplant. Like that it is there. The rules are there. Raghavendra sir, any comment on this?
Sir, actually, it is like it is divided for our state. It is divided into northern, western, and the southern regions. So, northern region, there is no suitable recipient. It goes to the western, southern. If there is no suitable recipient within the whole state, then it goes to the other state pool, the All India pool. When there is no suitable recipient in the whole country, because for heart, you see, there's a lot of calculation, the square meter, the height of the patient, the chest cavity volume, which whether the heart will fit into those persons. In a case where there is no proper recipient in the whole country, then it goes to the foreign citizens. That is how it is calculated, sir. And whenever we have the 18 months old child is from Andhra, TV Talayla Valundiruchunu Vandanga, it was brain dead. So in such situations, where the incident happened, if an other state person has had an RTI in our state, then there is no issue about that. If the incident has happened in another state like this 18 months old boy, we need to get a no objection certificate from the concerned police station where the FIR has been registered. And it is very easy. You just call that police sub-inspector, within 20 minutes, 30 minutes, they give the NOC through WhatsApp, a PDF file comes. So everything has been simplified nowadays.
So one question, sir.
Yes, ma'am.
Sir, transplant register on donor in case of brain death. அவங்களோட ஆர்கன்ஸ் வந்து at that time members அவங்க ஃபேமிலி மெம்பர்ஸ்க்கு யாருக்காவது தேவைப்பட்டா அவங்களுக்கு கொடுப்பீங்களா இல்ல வெயிட்டிங் லிஸ்ட் படி தான் நம்ம சஜஸ்ட் பண்ணுமா சார்?
Ma'am, actually நீங்க கேக்குறது வந்து directed donation. It comes under the directed donation system where the donor directs who should receive the organ. That is not permitted in our state or transplant. See, the body minus the organs belong to the family. The organs belong to the state. இப்ப கேட்டீங்கன்னா recently ஒரு ஊர்ல வந்து we had an incident where the daughter வந்து அம்மா வீட்டுக்கு போயிருக்காங்க. There had a fall. She became brain dead in a hospital. Incidentally, அவங்களோட தம்பி was in need of an organ. So the family wanted தம்பிக்கு தான் கொடுக்கணும்னு. He said no, but within few hours, the husband of that woman raised that the parents for the தம்பிக்கு organ வேணும், சன்னுக்கு organ வேணும்னு அவங்க ஏதோ பண்ணிருக்கலாம். So these are lot of issues involved here, which will be beyond imagination. நீங்க நினைச்சு பார்க்க முடியாத அளவுக்கெல்லாம் மக்கள் பேசுவாங்க. அதனால it is always safe. We always go by the rule book. No deviation at any point of time. The organs belong to the state. Only the state can allocate the organs based on the waiting list.
Thank Dr. Raghavendra sir for giving a nice lecture. And now we will continue with our discussion, sir. You please give your guidelines, sir. Thank you, sir. Thank you, sir.
Thank you so much. Thank you, everyone. Thank you.
God bless you, sir. Raghavendra, God bless you. Thank you.
Thank you so much, sir. Thank you, sir. Thank you.
Now I request our panelist, Ashok is there? Ashok? Rati madam is there? ESG?
Yes, sir. Yes, sir. I'm there, sir.
Yes, madam. You can give your views. To give your views about the in case of any brain death certification is being done, what you will do immediately after that?
Yes, sir.
How you will proceed? You give you your guidelines how we should follow it, so that it will be helpful to our IMA doctors.
Yes, sir. Yes, sir. Yes, sir. So, as you said, once the clinical brainstem death is made, the intimation will come to us. That is, the coordinators are being informed about that there is a donor in such and such area. So from that point, as Dr. Tirumurthy sir said, the concerned physician won't come into the picture. The transplant coordinator will come into the picture. Next, we start speaking with the family. As we all know that it's a very difficult situation to handle the family. First, we try to maintain a rapport with the family just to get their trust on us. Slowly, we always start with the eye donation because it's easy to move away with the eye donation before talking about the solid organ donation. If the family is okay for that eye donation, then slowly we'll move on to the other solid organs. In the meantime, when you are talking with the family, we can easily find out who is a key member of the family. That's the most important thing. Probably a child had a brain stem death, but parents may not be the decision maker because they were in grieving. In that case, either uncle or aunt may be the decision maker. So we'll try to find out who is the decision maker. So once it's been done, if the family is okay, it's not as easy as what I'm saying here. It will take sometimes 6 hours, 12 hours, maybe a day. We have to wait and be with the family for the entire day. And we have to make them to understand the patient is brain dead. If they are okay with that, then we started doing our procedures. We have certain forms as per the transplant. So we have to declare, we have to get consent from the family. We have to declare brain dead, consent from the family. Then our process will start by intimating the transplant team, sir.
Okay, madam. The Balakrishnan, your views.
Yes, sir. As Mrs. Radhi ma'am said, as the transplant coordinator, we are getting into the after consent for organ donation. So we will intimate and other like renal team. And if the patient is in MLC, means we have to go to the police and the forensic doctor also. So all the in-house team and other stakeholder hospitals recipient team to coordinate that for the particular retrieval time in the theater and get into.
So immediately after the brain death, sir, 1 minute, sir. Immediately after the brain death is being certified.
Yes, sir.
And
Yes.
the process is going on. Immediately,
Yes.
where you will inform from the hospital, from where the brain death is happened, where you will inform immediately.
Immediately we'll inform to manage consent retrieval
Will
team.
inform to transplant.
Yes.
Yes. Second team transplant.
That's what I want to know.
Yes, sir. We inform the
You will inform
transplant
to
first.
transplant.
Yes.
Yes.
Okay.
I will inform transplant. Within 5 to 10
So after
minutes.
that,
sir.
they will be
You have
doing the alerting time and all those things.
Yes, sir.
Yes.
Okay. So after that, what I want to know is, what are all the other procedures you will do? Because the donor is ready, the patient is being maintained with the inotrope and all those things. And
Yes.
what are all the forms you have that need to be filled up?
Yes, sir. We have Form 6, Form 8 is the organ donation consent form we need to get from the family. The close
Form 6
relative
is
of the
what, sir?
family.
Form 8.
Form 8.
Form 6 is?
Sir, actually
No, you
previously
told
sorry, sir. Previously we've been using Form 6. Now we are using Form 8. It comes under declaration come consent from the family. Bala, can you please explain?
declaration from consent.
And consent from
Yes.
the family, sir.
Hmm.
That is a one form, Form 8. Next is a Form 10. That is a brainstem
Form 10.
death declaration, sir, by the certified team of doctors. So these two forms for the non-MLC patients. If it's not a medical legal
So for
case,
MLC patients?
MLC patient, we have 3 more different forms. Like we have to intimate the police, that is a Form 1. Next, we have to request the police for the inquest, that is the intimation from Form 1. Next, we have to, there's a Form 2, it's called the organ functional status. What are the organs is being used? That should be certified by the forensic team. Next, third is the authorization for removing the organ. These 3 forms to be done from the forensic as well as the police department in case of MLC, sir. Form 1, 2, and 3.
The authorization form for
retrieval.
Retrieval, that you will sign, madam.
Sir, for our forensic department, sir.
Forensic consultant.
Consultant. From the GH
So
or from
police
the
inquest form is form 1. Form
Yeah,
1.
yes, sir. Yes, sir.
Organ status form is form 2.
Yes, sir. That our intensivist or the medical officer will give the consent for that organs.
Then authorization for retrieval.
That is from our forensic doctor, sir.
So 3 people are involved. Police,
Yeah.
then MO and the forensic people.
Exactly, sir.
Oh. These forms need to be filled up.
Exactly. In case of MLC, these
Along with
forms
the
needs to
form
be filled.
number 8, form number 10.
Yeah, apart from form number 8 and 10, we need for form 1, 2, 3 for the MLC patients.
This authorization for retrieval is form number 3.
Yes, sir.
Okay, madam. So these forms need to be filled up and given these are all to be submitted where actually?
Sir, actually, we will
Kept in
have
the
one,
register.
we will have one copy of the forms, and the police will have other copy of the forms. We scan all
2
these
sets you
forms.
will prepare.
Sorry, sir.
You will have 2 sets of forms.
Yeah. This form 9 and 10, this is for the non-MLC patients. We, not only for MLC and non-MLC, the form 9 and 10 is the common, sir. We will keep the original forms with us and we'll scan and send this form to Transtran. For the MLC patients, we'll give all these forms to the police department and the forensic doctor.
Original or duplicate?
No, sir, it's a duplicate form. That means the Xerox form.
Form 9 enna ma'am?
Ma'am, form 9 is for children, ma'am.
Okay.
If the children is a donor, we'll use form 9 along with this thing, ma'am.
Forensic department எதுக்கு ma'am MLC caseல இது பண்ணனும்? Brain death தான ma'am?
Ma'am, it's a brain death only for it's a medical legal, whatever it may be, it's a medical legal case, ma'am. It comes under police. So we have to get clearance from the police before proceeding with the organ donation, ma'am. Suppose if it's a poisoning case, we need their clearance. And if it's a RTA also, if it's a head injury, they will, and in case of hypoxic damage, whatever it may be, whatever the cases coming under the MLC medical legal case, we need a clearance from the police department to proceed further, ma'am.
Police okay, ma'am. Forensic department and
they will come and do the postmortem, ma'am.
Okay.
No, actually they will come and see the patient in the hospital.
Yeah. Yes, sir.
Okay.
They will do the postmortem
That
after
will
the
be much difficult, madam, some of the patients. If, for example, our hospital, Ganga Hospital, where we don't have this departments and all those things. So, in that case, we need to call from CMC, no?
So nowadays we have to call from ESI, sir, ESI Coimbatore. If we inform them prior, they'll come in proper time and they'll do the postmortem in our hospital itself, sir. So the postmortem formalities will be over in our hospital and they'll hand over the police will hand over the body to the family, sir. It is actually, if you see the RTA patients, we are sending them to the GH and for the postmortem, it takes long time. But if the family is willing for organ donation, the team is coming here and doing the postmortem, sir, actually. So one way it's easy
for
for
example, you are telling about authorization for retrieval of the organs, no? Forensic team, it is better to inform it to the people who are going to do the postmortem.
Yeah, so actually police will come and see, sir. First the concerned police will come, which area the accident has happened, they will come and see. They will also inform the forensic doctor. We also inform from our side and we'll tell them regarding the organ retrieval time. So before that also they'll see the patient. And after all the retrieval is over, the forensic team will come and they'll do the postmortem in the OT. Sometimes at the OT or we'll shift to the other areas and we'll do it, sir.
This authorization of retrieval is they will see the organs when we are operating. That's what, no? Meaning?
Yeah. Before starting the thing, they will see the organs, the quality of the organs.
Oh.
Yes, sir. So here the form 1, we have to intimate the police, sir. The form 2, which we get from MO from ICU team, we have to give to the forensic person. So the forensic doctor will allow to retrieve organ. Without retrieving, he can't assess the organ.
Yes.
Whether it's a poisonous or not. So based on ICU doctor certificate, intensive certificate, the forensic person will allow to remove the organ from the form number, form 3.
Exactly.
Organ retrieval status certificate.
Okay. Once the organs been given and all the things happen, so after that, what you will do? So once
Sir,
the retrieval and all these things happen, and after that, what is the other procedure?
Sir, usually
Immediately you will hand it over to the police.
Previously, police will be there. So when everything was over, the police will be there. Along with the police, we hand over the body to the family. And now the government has introduced a new thing that if there is an organ donor, they want to honor the organ donor. So either the district collector or dean of the hospital will come and honor the donors after the everything was over. Either putting some garlands or something, they will honor the donor. Now this is the thing introduced by our state government, sir.
Madam, once the organs been retrieved,
Yes, sir.
they will take the body to the postmortem, no?
Yes, sir. Postmortem will be done in the same hospital. Suppose if the donor is not a hospital, PSG hospital, for example, if organ is retrieved, the forensic team will come here and they'll do the postmortem here itself, sir.
It will be done by your PSG or it will be done by other?
It will be done by the forensic department from ESI hospital in our hospital. They will come here. The team will come here from ESI and they'll do the postmortem here, sir. There is no need to shift the donor body to GH or somewhere. They will do the postmortem in the same hospital, sir.
So after that, they will hand over the body to the relatives.
Yes, sir.
Okay. Saravanan sir and Tirumurthy sir want to ask any questions to these coordinators?
Sir, many times this felicitation of the donor family and acknowledging their selfless donation is will be motivating for other families to take up this decision of donation, sir. Actually, nowadays, this grief counselor, see this, there is a difference between the post of transplant coordinator and grief counselor. The grief counselor is the job of the grief counselor is done by transplant coordinators in many centers. So the grief counselor also has to be appointed in a transplanting hospital, and if they have a degree with the social work MSW, they can be recruited as grief counselors in the transplant hospitals, and they can be the first point of contact to the families regarding their grave prognosis that has been. They have to be physically available at the time the neurosurgeon or the intensivist are explaining about the grave prognosis and brain death declaration with the families. And if from that point the grief counselor should take over the counseling, because there should not be any gap in between the counseling sessions, because in a busy schedule of intensivist or a neurosurgeon or a neurologist, see, they can spend around 10 minutes of time with the patient family about this decision of donation. But the queries to the families, the family members will be continuously happening. Many a times, maybe around 6 to 7 times, the queries has to be cleared by the team of this transplant coordinator and the grief counselor. Only after successful clearance of all these queries, the family will be convinced for donation. So it is not a one-stop process, it is a continuing process. And if the transplant coordinator does that job in a good way, then many of the patients might get benefited. And I have to wholeheartedly thank Dr. Rajesh and to the organ donation committee in IMA to take this human task into the Zoom meeting level, and I will expect also this to be converted to the physical meetings in future. And one among the organ donation committee can take part in most of the state level meetings like this nursing home board meetings and FSS meetings and PPLSS meeting, and they can allocate some 10 minutes for this organ donation committee person to enlighten the IMA crowd who has been gathered there. And if all this is done, then we can expect a good future for this transplant, and this organ donation committee's job will be well done. Thank you, sir.
Sir, regarding this grief counselor and transplant coordinator, sir, what is the difference, sir? Can the same person can do, or we need to
That
separate?
is what is happening, sir. Actually, at present, the same person of transplant coordinator are doing the job of the grief counselor. The grief counselor should be only their job responsibility will be completed once the patient is accepted for donation and signed in that form. And then they will be taking care of the responsibility of giving the body back to the patient family. But transplant coordinator is not like that. They will be having a lot of report submission process to be completed for the recipient to the transplant team. So this grief counselor is more of donor related work. This brain-dead donor, family maintenance, family counseling, and this police intimation, all these things will be on more of donor family related works will be completed by the grief counselor, and more of recipient related works should be completed by the transplant coordinator. For a grief counselor, also the base requirement for them to be posted as grief counselor is MSW degree and or one because there are a lot of transplant coordinator course also. It's there in Mohan Foundation. I personally have made 4 to 5 of my dialysis technicians to complete that certificate course of transplant coordinator course. And by doing all these things, by educating the dialysis technicians and other good, bright staff nurses, they can get converted to a successful transplant coordinator. And if there is no grief counselor available in that hospital, only the transplant coordinator has to be completing all those things also.
Sir, regarding the conducting of the meeting, you were telling that we need to conduct in the IMA, sir. How many doctors are attending, sir? No one is attending. That is the big problem, sir.
Sir, Erode IMA, we have attendance of around 100, sir, every month.
சார் ஈரோட்ல வந்து நீங்க எல்லாம் நல்லா வருவாங்க சார், பட் எல்லா இடத்துலயும் அந்த மாதிரி வர்றதில்ல. ஈவன் கோயம்புத்தூர்ல எடுத்தீங்கன்னா நீங்க வந்து 2500 பேர் இருக்கிறாங்க. Less than 100 people only will come for the meeting. That is the big problem. So நீங்க வந்து நீங்க சொல்றீங்க நீங்க 100 people வருவீங்கன்னு சொல்றீங்க. உங்களுக்கு ஈரோட்ல வந்து 1000 பேர் இருக்காங்க இப்போ மெம்பரு.
1200 பேர் இருக்காங்க சார் மொத்தம்.
அதுதான் சார் சொல்றேன். 1200 பேருக்கு 100 பேர் வந்து அட்டெண்ட் பண்ணா அவங்களுக்கு எப்படி நாம டீச் பண்றது? அதுதான் இப்ப பெரிய ப்ராப்ளம். இப்ப நாம ஒரு பேம்ப்ளெட் போட்டாலும் சரி, ஒரு ரைட் அப் எழுதி கொடுத்தாலும் சரி, இந்த மீட்டிங்ல வந்து எவ்வளவோ இன்ஃபர்மேஷன்ஸ் we have changed in a lot of things. A lot of guidelines we have created. இதெல்லாம் வந்து எப்படி ரீச் ஆகும்? வெரி வெரி டிஃபிகல்ட். அதனாலதான் லாஸ்ட் டைம் வந்து இவர் கோபாலகிருஷ்ணன் சார் வந்திருந்தாரு மீட்டிங்க்கு. அவர் வந்து சொன்னாரு, நீங்க எவ்ரி ஐஎம்ஏ மீட்டிங்ல வந்து every IMA meeting you should allot around 5 minutes வந்து அலாட் பண்ணிட்டு அதுல வந்து ஆர்கன் டொனேஷன் பத்தி ஒருத்தர் பேசணும். அதே மாதிரி அவர் வந்து இப்போ வெயிட்டிங் லிஸ்ட் என்னன்னு சொல்லிட்டு சொல்லணும். அப்புறம் வந்து அதே மாதிரி இப்போ நீங்க மாதிரி ரெப்னாலஜிஸ்ட் எல்லாம் இருக்கிறீங்க, உங்க எக்ஸ்பீரியன்ஸ் சொல்றது, how you created a patient to donate the organ, how you arranged all those things. So இந்த மாதிரி இதெல்லாம் வந்து you need to plan and discuss.
எங்க செட்டப்ல எல்லாம் பார்த்தோம்னா சார், the nephrologist also has to be continuously guiding the coordinators, because the coordinators will be new to the all these regulations and legalities. இப்போ பார்த்தோம்னா ஒரு கெடாவரிக் ஆர்கன் டோனர் வந்து நம்ம ஹார்வெஸ்டிங் சர்ஜரி முடிஞ்சு உங்களுக்கு வந்து அந்த சர்ஜரி டிரான்ஸ்பிளான்ட் முடிஞ்சு வீட்டுக்கு போறதுக்கு வந்து it will take 48 hours. That 48 hours we have to be in the hospital. We cannot even go to the home, because if we go to home and come back, the motivation level, everything can get spoiled. So பார்த்தோம்னா அந்த அளவுக்கு வந்து it is a very tiring job தான். But in some centers it has already been the transplant coordinator வந்து ஃபுல்லா அந்த ரோலை எடுத்து நிறைய எக்ஸ்பீரியன்ஸ்டு டிரான்ஸ்பிளான்ட் கோஆர்டினேட்டர்ஸ் இருக்கிற இடத்துல இது வந்து ரொம்ப ஈஸ்ட் அவுட்டா முடியும். பட் அதுக்கெல்லாம் முன்னாடி வந்து நம்ம ஃபர்ஸ்ட் சொன்ன அதே ஹர்டல் தான் சார். நிறைய இடத்துல பல பிரெயின் டெத் பேஷண்ட்ஸ் இருக்காங்க, பல ஐசியூஸ்ல. பட் அந்த ஒரு ஹெசிடன்சியை வந்து போக்கி இந்த பேஷண்ட்டுக்கு நம்ம பிரெயின் டெத்தை டிக்ளேர் பண்ணணுங்கிற ஒரு ஹார்ட் ஆஃப் த ஹார்ட் டிசிஷன் எல்லா நியூரோ சர்ஜன்ஸ் அண்ட் நியூராலஜிஸ்ட், இன்டென்சிவிஸ்ட் அண்ட் ஹூவர் தி ட்ரீட்டிங் பிசிஷியன் இஸ், அவங்க எடுத்தாதான் சார் முடியும். இப்ப இதுல என்னன்னா, ஒரு பிரெயின் டெத் பேஷண்ட்டுக்கு ஒரு ட்ரீட்மெண்ட் வந்து கண்டினியூ பண்ணிட்டு இருக்கிறதுங்கிறது இட் இஸ் அ யூட்டிலிட்டி ஆஃப் பிசிக்கல் ரிசோர்ஸ். இப்ப வந்து ஒரு எக்கனாமிக் ரிசோர்ஸ் அங்க ஸ்பெண்ட் ஆகுது. அந்த ஒரு ஹியூமன் ரிசோர்ஸ் இப்ப வந்து ஒரு ஸ்டாஃப் நர்ஸ் அதை பாக்குறாங்க, ஒரு டாக்டர் அதை பாக்குறாங்க, ஒரு பெட் ஆக்குபைடா இருக்கு. அண்ட் இந்த மாதிரி வந்து பல்வேறு விஷயங்கள் அங்க வந்து இட் ஹஸ் பீன் யூஸ்ட் வித்தவுட் எனி யூஸ். ஸோ இந்த பிரெயின் டெத்துன்னு வந்து ஒரு டிக்ளேர் பண்ணி அதுக்கு மேல பேஷண்ட் வந்து இல்ல நாங்க வந்து இன்னொரு 2 days நீங்க கண்டினியூ பண்ணுங்க, நாங்க வந்து 2 days கழிச்சு கூட்டிட்டு போறோம்னு சொல்றது வேற, அந்த பிளக் ஆஃப் பண்றதுக்கு வந்து டைம் டிலே பண்றது வேற. பட் பேஷண்ட் கிட்ட அட்டெண்டர் கிட்ட வந்து அந்த ஒரு பிரெயின் டெத் ஆயிட்டாங்கிறது சொல்லாம இருக்கிறதுங்கிறது என்னை பொறுத்த வரைக்கும் ஒரு பெரிய ஒரு ப்ராப்ளம். அண்ட் நான் ஐ ஹாவ் இப்போ எங்க ஐசியூலாம் பார்த்தோம்னா எல்லா பேஷண்ட்ஸையும் கூப்பிட்டு உள்ள வந்து அட்டெண்டர்ஸை கூப்பிட்டு காமிச்சிடறோம். ஓப்பன் டிரான்ஸ்பரண்ட் ஐசியூ இருக்கும்போது பார்த்தோம்னா இது வந்து ரொம்ப எர்லியரா வந்துடும். அண்ட் க்ளோஸ்ட் ஐசியூஸ்ல கொஞ்சம் நம்ம வந்து இந்த ஐஎம்ஏ மாதிரியான ஒரு பாடி, ஒரு என்ஜிஓ பாடி வந்து வி ஹாவ் டு மேக் மோர் அண்ட் மோர் டாக்டர்ஸ் டு டூ த பிரெயின் டெத் டிக்ளரேஷன் அட் அ எர்லியர் திங், ஸோ தட் அந்த ஃபேமிலியோட ஃபண்டுக்கும் வந்து அப்போ வந்து அன்னெசரி வேஸ்டேஜ் ஆஃப் தேர் ஃபண்டும் இருக்காது. ஒரு டொனேஷன் பத்தி ஒரு பாசிட்டிவான ஒரு விஷயமும் எடுப்பாங்க சார். இதைத்தான் நான் ஃபர்ஸ்ட் எடுத்தோன்னு சொன்னேன். இதை வந்து நம்ம ப்ரொபகேண்டா பண்ணணும், மோட்டிவேட் பண்ணணும். எர்லியர் பிரெயின் டெத் டிக்ளரேஷன். ஒரு பேஷண்ட் டீப் கோமா ஸ்டேஜ்ல 24 hours இருக்காங்களா, ஒரு அப்னியா டெஸ்ட் பண்ணிடுங்க. ஒன்றும் இம்ப்ரூவே ஆகலையா, எப்போ பார்த்தாலும் வெண்டிலேட்டர் டிபெண்டாகவே இருக்காங்களா, ஒன்று அப்னியா டெஸ்ட் பண்ணுங்க. ஒரு அப்னியா டெஸ்ட் பண்ணிட்டு அதுக்கப்புறமேல செகண்ட் அப்னியாக்கு வந்து இன்டிட்டர்மினேட்னு வருதா, தப்பு இல்லை. அப்னியா டெஸ்டே பண்ணாம இது வந்து போஸ்ட்போன் பண்றது தப்பு. அதுதான் சார்.
என்ன சொல்ல வரீங்க சொல்லுங்க.
Let me clarify certain points. ஏன்னா என்னன்னா பிரெயின் ஸ்டம் ஃபங்க்ஷன்ஸ் ஃபர்ஸ்ட் இல்லைன்னதுக்கு அப்புறம் தான் அப்னியா டெஸ்ட்க்கு போக போறோம். பிரெயின் ஸ்டம் ஃபங்க்ஷன் இல்லைன்னு வந்தாச்சுன்னா அது ஃபர்ஸ்ட் டாக்குமெண்ட் ஆயிரும். அதுக்கப்புறம் அப்னியா டெஸ்ட்டுக்கு போறது அந்த ப்ராசஸ் மேபி இட் வில் டேக் சிம்பிள். Clinically, if patient is going to have any brainstem reflexes being absent, it will be notified. அது நிறைய இதுல பண்ணிடுவாங்க. அதுக்கப்புறம் இந்த ஆப்னியா டெஸ்ட் பண்றது, இந்த இதுக்கெல்லாம் வந்து அவங்களுக்கு பேசுறது பண்றது, இப்ப அதனாலதான் இப்ப நிறைய சென்டர்ஸ் என்ன பண்ணிருக்காங்கன்னா கிளினிக்கல் எவிடன்ஸ் வந்த உடனே அலர்ட் ஆயிடுறாங்க, டிரான்ஸ்பிளான்ட் டீமுக்கு அலர்ட் பண்ணிடுறாங்க. இந்த மாதிரி ஒரு பொட்டன்ஷியல் இது இருக்காங்க அப்னியா டெஸ்ட்டுக்கு அப்புறம் அவங்க வந்து பொட்டன்ஷியல் டோனர்னு அதுக்கப்புறம் தான் பிராண்ட் பண்ண முடியும். பிஃபோர் தட் அப்னியா டெஸ்ட் இது பண்ண முன்னாடி நம்ம வந்து பிரெயின் டெட்னு நம்ம சொல்ல முடியாது. ஸோ அந்த ஒரு டெக்னிக்கல் இஷ்யூ இருக்கிறதுனால தான் நிறைய இடத்துல பீப்புள் ஆர் லிட்டில் ரிலக்டன்ட். ஏன்னா அந்த இன்டென்சிவிஸ்ட் பண்ணணும், கரெக்டா இருக்கணும், பேராமீட்டர்ஸ் கரெக்ட் பண்ணணும், இந்த மாதிரி இஷ்யூஸ் இருக்கும். சார் ஆஸ் அ நெஃப்ராலஜிஸ்ட் வில் நோ. இங்க நமக்கு ஒரு பெரிய கார்பரேட் செட்டப்ஸ்ல இல்ல பெரிய இன்ஸ்டிடியூஷன்ஸ்ல வி ஹேவ் அ டீம். பட் அதே ஒரு சின்ன செட்டப்ல அதுக்கான பாசிபிலிட்டி சில இடத்துல விசிட்டிங்கா தான் இருப்பாங்க சில பீப்புள். அவங்கள வந்து கோஆர்டினேட் பண்ணி பண்றது கொஞ்சம் டிஃபிகல்டிஸ் இருக்கலாம்னு I feel so. அந்த ஆஸ்பெக்ட்ல IMA has to think what can be done from their side to overcome such things. ஏன்னா பெரிய செட்டப்ஸ்ல they will have consultants. ஒரு சில மாதிரி ஆப்ஷன்ஸ் இருக்காது, விசிட்டிங்கா தான் இருப்பாங்க. அந்த மாதிரி சிச்சுவேஷன்ல என்ன பண்றதுங்கிறது I think IMA should put in their thoughts regarding those areas where there are potential people who are going to be there, how to coordinate and get it into the stream. I think I have to thank.
So it was a very nice discussion for the organ donation committee meeting. It was well done by our Professor Dr. Raghavendran sir, and felicitations all given by our office bearers, senior members, and very well moderated by Dr. Saravanan sir, the president of IMA Erode, and Dr. Tirumurthy sir, the neurosurgeon from PSG Medical College, professor, and other coordinators, the Balakrishnan from Royal Care Hospital, and Radhi R from PSG Hospitals, Coimbatore, have already cleared our maximum doubts, whichever we had. I thank one and all the participants. Without participants, we cannot have a nice meeting. I thank the participants for coming and attending to the meeting full. Thank you, one and all.